Well, I was pleased to be hired on by ABC Hospitals as an instructional designer to be a team leader in the instructional design for providers in this hospital system. So there's a couple questions we need to ask as we begin to specific role as the designer. Well, I'm going to consult and collaborate with subject matter experts, Tracy and Morrison, assess the need for instruction. The role of the ID professional is to assess which problems can be solved by instructions and which are organizational process issues which can be addressed internally. And identify project team members to serve as the subject matter experts. These team members are stakeholders. As members of the instructional design team, I would clarify the client's problems which were discussed during the initial consult. I would identify these stakeholders which would become the actual subject matter experts, which would include a member of the hospital executive group, probably the CEO, the medical director, whom I actually met with and spoke with, and who actually hired me for this design project, the pharmacy director, the laboratory director, health information management manager, information technology supervisor, quality assurance manager, and end users. All of these are important in this with these safety issues that were addressed, these medical errors. They become important subject matter experts in designing this training program. The role after this consult, we found multiple forms of possible medical errors that are become safety issues in patient care. These are problematic. The drug interactions, these occurred when patients came in to the hospital and had a former medications, and then while having the hospital event, more medications were added to their record, and sometimes that created medication errors and interactions. Also, there was insufficient documentation within the providers. That documentation is actually 2 layers, having to be with charting delay or having it not being completed, and then a second layer would be providers could not find the records within the patient chart, so either mislocated or not located or completed could have been that issue. Those things will be discussed and made more clear. The illegible documentation, really, this is a human performance process issue that does not require instruction. With the advent of the technologies that we will hopefully integrate for this multi-specialty and clinic healthcare system, we'll achieve that without having to go any further, using the electronic means to data entry physician orders, which will be coming. And then the CD-ROM program on chart management and maintenance, it may not be specific enough, or the medical director said it wasn't effective for them, and that has to be investigated a little further to find out what that means. How come it was not effective? Is it not up current, or what is the issues with that CD-ROM program? And 2, does the hospital now have an electronic health record that makes that obsolete? And they need to be trained on how to use the electronic medical record more efficiently. We need to address is the instructional design context, the learner context specific to the healthcare setting, and as working adult professionals, highly educated professionals. Also, how about prior performance improvement training activities and outcomes? What do they do? How were those meetings conducted, and what were the outcomes of those would be important to know. How about the learning theory based on problem-solving focus? I note that because this learning theory is actually problem-based learning, and the use of technology tools are part of the learning strategies in provider education and practice, as noted by Locatus 2018. The design would include problem-based learning activities, certainly within it. And then how about time and the technology infrastructure? What electronic health information records management software or web-based systems are used in the hospitals and clinics? And then can these systems share data, connect, collaborate, and transfer between patient to patient? Those would be investigated, certainly. What is their technology? And the electronic health record would help connect records together and help reduce medication errors in itself. That's the design of the electronic health record. And then the time and resources. Lutgen, Sandvik, and Cipher 2009 note contemporary technologies communicate and share information faster at lower costs and to more people. Certainly the ID project team would be encouraged to use contemporary technologies to communicate and collaborate frequently. And as we have to address the determining the societal and learner culture factors in this context. What is the provider practice culture within the hospitals and clinics? The outcomes of prior performance training. Which organizations are responsible for provider training and education? Are credentialed providers required to comply to organizational policies and procedures? Who supervises provider practice and privileges within the hospital organization? Can the organization require mandatory provider training? I think they can. Who will oversee and record provider training requirements? That will be a person in probably the medical director and credentialing staff. Are there technological barriers for providers to embrace or to overcome? This will certainly be discussed as we meet with those who would be stakeholders and subject matter experts as well as end users. That's an important matter for all of them involved in this project. And then what forms of communication tools are preferred methods of training and provider participation? All of these. What are the contextual restraints because of the context of the hospital and providers and professionals? Certainly it's been noted on consult, time and resources is an issue. Project team as the subject matter experts with their time constraints. Budget limits for instructional design. Project team meetings, time, locations, and the technologies which can be used. And also external. The time and resources are going to be impacted, will be benefited by the instructional design model that is selected. And because of these constraints, the use of the successive approximation model, the SAM design model, will be attempted to prevent or overcome the constraints identified by either me personally as the designer or by those who will be the subject matter experts. And then within that, we have the resources issue will be use information and communication technologies to reduce travel and face-to-face interactions while increasing collaboration during project team efforts. We will use a 2-day meeting called the Savvy Start from Successive Approximation Model for Design. This phase 1 is a preparatory background exploration phase, which includes the project team or stakeholders, and it is a brainstorming session to identify multiple design prototypes for the training program. This is an intensive 2-day schedule among these essential subject matter experts. And then how about the project team subject matter experts? Identify the primary opportunity. This is a big thing for these people, is to identify the organization's primary opportunities to improve patient safety to meet patient care goals. and by accreditation and by payer source requirements. During the Savvy Start meeting, the company culture is discussed and the project cross-functional teams are organized. The budget limits. The cost of information technology continues to decline. It becomes more feasible. Look at us. The design would include the successive approximation model for smaller design projects using the 2 phases, the expeditious, preparatory, background exploration phase, and 2, the design and development phase. This model takes less time, minimizes documentation, and is an effective model to use with limited resources and budget. Allen and Merrill, 2018. The location, time. As the cost of information technology continues to decline, it becomes more feasible for us to use and invite the technology of the day to collaborate and engage when not in face-to-face discussions, which can also be more efficient for time. And then external factors help drive the need for training, patient safety goals by accreditation bodies, and impact service reimbursements. Those are important motivators for efficient and effective training. Technology integration model, which I'd select to guide the design for these training of healthcare providers. Well, the technological, pedagogical, and content knowledge, the TPAC model, is the one I would select. It is the illustration is through K through 12, but I think it's very applicable for any age group, and thus I adapt it for even adult learners. The focus is on the instructor to effectively consider in treating technology to support instruction. That's by Albright, Leftwich, and Brush. Healthcare settings have the contemporary technologies to integrate into instruction and learner or provider training. The U.S. legislative acts mandate hospitals acquire electronic health records. This will support this model of technology integration, both as the instructional designer and with the learner. And then the software is available within this hospital system. A product by Cerner and or by Epic are robust electronic health record systems with hospitalized, computerized physician order entry for healthcare providers. It's noted that the computerized physician order entry, that will take place of the poor penmanship when orders have to be noted within the system. That will also help flag potential for medication errors, and that's why that becomes important. So this concludes, and the final list is the references. Thank you. Bye.